Um, Good afternoon, everyone. My name is Fran Bergen. I am part of the Alabama Perinatal Quality Collaborative, and we are so excited for our Iowans who are joining us on the call, and then folks from potentially all over. We put it out there for invitations on the national network as well. Today, I have the pleasure of introducing Dr. Stephanie Radke. Um, what more fitting speaker could we have today to talk about utilization and implementation of Category 2 EFM algorithms than someone whose professional focus is quality and safety as a strategy to improve maternal health outcomes at the population level? If that doesn't scream perfect for this job, I don't know what does. Dr. Radke is a native Iowan. She received her training from the University of Iowa in terms of medical school and then went to residency at the University of California at Davis, followed by 3 years in community practice in Sacramento. She returned to Iowa to join the faculty at the university in 2016 and is currently a clinical professor and practices as a laborist. She founded and is the executive director of Iowa's Perinatal Quality Care Collaborative. She is also the co-director of the statewide perinatal care program, the chair of the Iowa Maternal Mortality Review Committee, and the PI of Iowa's HRSA Maternal Health Initiative Award. So not sure why she might consider herself busy, but doing all that plus her clinical practice. She's also formally trained as an improvement advisor through the IHI. Her research interests are far and wide, but include the quality improvement methodology reviewed above, as well as lactation and breastfeeding medicine and geographic disparities in maternal health. And without any further ado, I will give the floor over to Dr. Radke. Thank you so much for joining us.
Yeah, thank you so much. I'm really happy to be here and talk about this. I'm going to get my slides up. All right. Do these look normal? Great. Sometimes Zoom does that thing where it decides that everybody wants to see your speaker notes. Well, I'm really excited to talk about Category 2 algorithms today. I think this is a really foundational part of work around appropriate use of cesarean sections, and I'm excited that you guys want to dive into this. Just acknowledging that my work in this space, particularly around cesarean reduction, was at the time funded by our Maternal Health Innovation Award and our AIM grant in Iowa. And I did take pieces of this presentation from previous presentations I gave during that time. But largely you're hearing my opinions and citations as noted throughout the presentation. So these are the objectives that we put together for this talk for today. So I'll talk about some of the rationale for using Category 2 algorithms. I'm really hoping for the audience to understand that this isn't necessarily my opinion that you should use a Category 2 algorithm. This is This is really an evidence-based strategy to provide the best care possible to people in labor. And then we'll get into, how do you actually use them? What are some strategies to implement Category 2 algorithms in your own practice or on your unit? And then also, how can you use these algorithms if you're doing chart reviews and trying to understand if your unit or your facility has an opportunity to reduce cesareans or reduce neonatal adverse outcomes potentially with these algorithms. So the roadmap we're going to go through is I do want to ground us first by talking a little bit about unplanned cesarean delivery, briefly touch on NICHD EFM interpretation. That is not the purpose of this talk, but it is foundational to have this conversation. And then we'll really get into our objectives, introducing the algorithms for anybody who may not be familiar with them, and then thinking about how to incorporate them into practice and into your case reviews. So starting with thinking about unplanned cesarean delivery. So I always want to acknowledge and make sure that everybody understands that I I'm not here to say that we never do cesareans. I am, as noted, a practicing OBGYN. I do lots of cesareans, and we know that C-sections can be life-saving interventions in many situations. But we also know that we can overdo it. So we're really thinking about appropriate use so that we are minimizing maternal and neonatal adverse outcomes. But we're only using it when we think that the benefit of the intervention outweighs the risk. And there is reasonable population recommendations from the WHO that when we look at country level cesarean rates, so really high level population rates, that if it's less than 10%, we see that outcomes are worse for moms and babies. But when we get above 19% for overall cesarean rates, we really don't see further improvements in maternal or neonatal mortality. And we can actually start to see worsening mortality related potentially to cesarean overuse. So we're really kind of trying to find that in the middle place where we're using cesarean as an appropriate intervention, but not overusing. And I think one of the challenges, particularly when it comes to fetal heart rate pattern interpretation, is that we can find ourselves with an ambiguous or indeterminate fetal heart rate pattern. We are all here to have good outcomes for our patients, and so there can be concern that the baby may be in trouble and that there's going to be an adverse outcome. We perform a cesarean and we get a good baby, and so we've actually reinforced the idea that that was the time to do the cesarean to have a good baby. And then that kind of leads to a reinforced practice loop that might be a little bit defensive or a little bit conservative. And what we don't really know is how many of those babies that we were worried about actually would have done just fine if we didn't intervene with a cesarean, because we don't go down that path. And this is where I'm hoping that this talk will help you see how you can go down the path of perhaps not performing a cesarean with good tools behind it, but then also making sure that we are intervening when we should. So, not going to belabor the point, but we know that there is short-term morbidity associated with cesarean as compared to vaginal birth, hemorrhage, infection, blood clots, complications of anesthesia, longer recovery and hospitalizations. We also know that following the first cesarean, that every subsequent pregnancy is inherently higher risk, including placenta accreta, uterine rupture in or outside of labor, surgical complications related to adhesions, organ injuries, greater likelihood of hysterectomy, severe hemorrhage or ICU admission in women who have a previous C-section in their pregnancy. At the population level, we also know that higher cesarean utilization increases healthcare system costs, largely related to longer hospitalizations and more expensive care. And so all that in mind, we want to think about doing the right cesareans, not necessarily around like having a certain rate. We shouldn't be thinking about our C-section rates, on an individual level when we are taking care of a patient. We should take care of the patient ahead of us. But we should still be thinking about, again, like make sure we're doing the right ones. So some of the strategies that are recommended in general to reduce overuse of cesarean are evidence-based approaches to labor management, including cervical ripening, appropriate patient preparation for their expected course of care, including shared decision-making, continuous labor support and use of doulas, and standardization of fetal heart rate interpretation. And so that's obviously where we're focusing today. But these other things should be part of your approach if you are here because you are looking to potentially lower the C-section rate in your hospital. Okay, so just a little foundation. We can't talk about category 2 algorithms without talking about NICHD categorization of fetal heart rate patterns because it builds on that. So we're just going to briefly review that. But again, I know that probably everybody already knows this, and it's not the purpose of today's talk. So why do we have a 3-tiered system? Why did NICHD come up with this? The goal was really to have a standardized framework for interpreting fetal heart rate patterns to promote good team communication and help guide assessment and management during labor. But recognizing that the fetal heart rate pattern is just one piece of information and needs to be kind of interpreted in the context of what is happening overall for that pregnancy and that labor. We have our 3 categories. Category 1 is our normal tracing. We know that these are babies that have normal acid-base status. Category 3 is very abnormal. We know that this is predictive of abnormal acid-base status when it persists and requires prompt intervention. And then we have our Category 2 that is not predictive of either normal or abnormal and requires ongoing evaluation and clinical judgment. These are the criteria for each category, which I'm not going to read because this is kind of foundational EFM. But just want to note that within Category 2, specifically what the Category 2 algorithms are helping us with is what I observed to be one of the most frequent reasons that a tracing becomes Category 2 is that we generally have normal variability, but we are having decelerations. And so this is really to help us understand what to do in this situation. So what is recommended by NICHD? Category 1, we don't really do anything. Category 3, we need to resuscitate, evaluate for reversible causes, and expedite delivery. And so again, this isn't what a Category 2 algorithm is for. It is for Category 2. And in Category 2, we need to be assessing the maternal, fetal, and labor status. We need to be initiating intrauterine resuscitation. And then we need to reassess. We need to reassess for progression or resolution of the Category 2 tracing. And so again, the algorithm helps to, or there are two algorithms, they help to provide a little bit more structure to what we might do here, and particularly to that reassessment piece. So there's limitations to the three-tiered system. It can sometimes be challenging to visually differentiate between absent and minimal variability, which will, make your tracing either Category 2 or Category 3. I think we all know that the majority of tracings are Category 2 at some point, which is what becomes really ambiguous. Plenty of studies showing that there's a lot of inter-observer variation in how people interpret and manage Category 2 tracings. Again, that's what we're here for. And limited specificity, right? We know that a Category 3 tracing reflects a baby that is in trouble, but we really don't know if the Category 2 tracing reflects a baby that's in trouble or not. And again, that's kind of what we're here to talk about. I do want to acknowledge just some of the other systems that are out there in the literature that people might be thinking about if you've been thinking about how to standardize or optimize how fetal heart rate patterns are looked at in your organization. There's a 5-tier system that actually has great evidence behind it, but I will be honest, it's very complicated. That's what I've got on my next slides. And then there's a kind of a flow chart that I'll show as well that another author has put forward. So this 5-tier system, some people may have heard of. This was published a while ago. But what they did is they kind of look at all of the different things, what is happening with your baseline, what is happening with presence or absence of decelerations, all of these things, and then you grid out into all possible different combinations. And so I'm actually only showing you those for moderate and minimal variability. There are grids for the other variabilities. And then based on kind of how you grid out, you fall into a color category based on that. And then for each color category, it's outlined, what is the risk of acidemia for that fetus, the risk of evolution, and what action is recommended. And then what I do think is really nice about this one that is really actionable, particularly for community hospitals where you may not have everybody on labor and delivery all the time, is that they do have some suggestions around like what are your resources that should be available, and are they informed? Are they at the bedside? Like, are they available at the bedside, informed? So I do think that this is useful. But I think that anybody who's really tried to put this into place, this gets really complicated. But I just want to highlight that this does have really good evidence behind it and is another strategy that one could consider. Okay. And then, as I mentioned, there's another paper that I also think does a nice job, and this is kind of an opinion piece of these two physicians, but really talking about that the deterioration from a normal tracing to a severely abnormal tracing that may reflect a baby that is going to be experiencing HIE frequently follows kind of a pattern of deterioration. And so they've mapped out, what does that pattern of deterioration tend to look like? And recognizing, as I think we all recognize, there's kind of a component amongst category 2 where we're still kind of concerned about the baby. And so they have their cut point in their 3 levels of green, yellow, and red it's within category 2. And so then they kind of highlight this portion of category 2 where you may be developing acidemia. And then, you move into category 3, and then they provide some recommendations that you really shouldn't be in this red zone for more than 1 to 2 hours. So this is another strategy that I think is a little bit simplified. The challenge with this is that not every tracing that may deteriorate is going to follow this pathway. This is just a common pathway. So just pointing out these 2 other tools that do exist out in the literature. Okay, and then I do want to highlight, I don't think there's anything too different from other national guidelines, but ACOG does have a very recently updated clinical practice guideline related to intrapartum fetal heart rate monitoring that I think is quite useful. It goes over intrauterine resuscitation, tracing interpretation, etc., and I think can be a really useful guide that I'd encourage people to read. I'm not going to go into the details of intrauterine resuscitation today. So there's some comments in there about that. Okay, so that's kind of our background. So let's talk about the algorithms. So one of the things that I think is really important for people to understand about the algorithms is that these were not developed to reduce cesareans. These were developed to identify among category 2 fetuses, those that are at the highest risk of having acidosis and potentially developing HIE. And so the algorithms were really designed to improve neonatal outcomes. They were not designed to reduce cesarean. And I think what is interesting is that many institutions find that they do also reduce your cesarean rates. And they most importantly help you do the right cesareans, right? Because that's really what this is about, is doing the cesarean when it is indicated and not doing it when it's not necessary. The algorithms are also guidelines like many other things in healthcare. This really isn't a policy. The algorithms are meant to apply to healthier pregnancies, not saying that somebody with preeclampsia or something like that can't use the algorithm. They absolutely can, but I think you have to be thoughtful. This is really for term infants and maybe healthy late preterm infants. If you are inducing labor of a growth restricted 36 weeker that's severely growth restricted and has abnormal Dopplers, then a category 2 algorithm maybe isn't exactly going to apply because that fetus has a lot less reserve, right? So we're generally talking about healthy term or near term fetus. And by healthy, I guess maybe the best way to say is that they're normally grown. The algorithms also really build on a foundation of EFM knowledge, and so they cannot be safely used if somebody really cannot accurately assess variability, if they cannot accurately assess the baseline, if they cannot accurately assess the types of decelerations. And so algorithms are now incorporated into many EFM education programs, such as the Iowan EFM courses. But it's important to understand that if staff does not have formal training in EFM, that you can't just hand them the algorithm and have them use it. They need to have that foundational knowledge. But the benefit of the algorithm is that it just really provides more specific and objective recommendations around assessment and response to category 2 tracings while remaining in alignment with NICHD guidelines for management. So this is the first published algorithm. It was published in 2013 by Dr. Clark et al. It's often referred to as the Clark algorithm. And again, this builds on the NICHD definitions. What's important to note is that this is a consensus opinion piece. And so this isn't a clinical study. The group of authors that are listed here gathered and essentially developed an algorithm that they felt was reasonable. And really the foundation is looking for presence of accelerations or moderate variability as indicators of fetal well-being, but doesn't really differentiate between them. They're both indicators of fetal well-being. So here is the Clark algorithm. And so you can see here, I'm going to move my little view of you guys. So you can see that the first thing that the algorithm is looking for is there moderate variability or accelerations? And if the answer is yes, then this means that that is generally reflective that the fetus in this moment has normal acid-base status and is reasonably oxygenated. And then we're asking, are we category 2 because we're having significant decelerations with more than half of contractions for the past hour? And if we're category 2, but not that, like let's say we're having some variable decelerations, but they're with less than half of contractions, this is the piece where I think we avoid some cesareans because it helps you understand that that's a tracing that you can just observe. If we are having significant decelerations with more than half of contractions persistent for at least an hour, then we are assessing where are we in labor. If we are just getting started, if we are cervical ripening and we're, 2 centimeters dilated, then we probably need to abandon this labor. If we are in active labor and we're having normal labor progress, we can probably observe and continue to reassess. If we are pushing and having normal labor progress, we can keep pushing. But you can see that if we are not having normal labor progress in the presence of this pattern, we're going to move towards expediting delivery. Now, if we don't have moderate variability or accelerations, then we have a lower threshold. We're looking to see, do we have significant decelerations with more than half of contractions for the last 30 minutes? And if the answer is no, then we're going to observe and reassess what that pattern does. If the answer is yes, then we probably need to expedite this delivery. So the second algorithm I tend to refer to as the Shields algorithm, published by Larry Shields and developed by the group of authors here. And so this algorithm was published as a clinical study. And so these individuals were leadership within a large healthcare system on the West Coast at the time called Dignity Health. And they took the Clark algorithm and they wanted it to be just a little bit more specific on labor progress and have a little bit more specificity on reassessment. And they then introduced this, and in their study, they recruited several hospitals within their healthcare system to implement the algorithm. And their goal was to reduce adverse neonatal outcomes. And so their primary study outcome was 5-minute APGAR scores less than 7, and then severe unexpected newborn complications. And their secondary outcome was their C-section rate. So among the participatory hospitals, the algorithm was determined to have been followed the vast majority of the time. And what's notable is that for their primary outcomes, they reduced low 5-minute APGARs by 24%. They reduced severe unexpected newborn complications, or PCO6, by 26%. And they actually had a modest decrease in their primary cesarean by 1.5% from 19.8 to 18.3. I think what's worth noting is that this is a fairly low primary cesarean rate to start with, suggesting that they maybe did a few fewer C-sections, but they probably did the right C-sections because they had improvement in their neonatal outcomes. I have observed in Iowa hospitals that have implemented this, that if they had quite a high C-section rate to start with, that this is a really useful tool to help them bring their C-section rates down without having any adverse neonatal outcomes. So here is the Shields algorithm. And so you can see that it separates on the left-hand side, the algorithm describing moderate variability, and then the right-hand side is minimal variability. So a little bit different than how the Clark one is organized. But again, very similar things. So they're looking at, on the moderate variability side, you have significant decelerations with greater than 50% of contractions for 30 minutes. And on the right-hand side, with minimal variability, they're looking at, do you have significant decelerations with more than 30% of contractions for 30 minutes? So a little bit shorter time period that they are asking for initial assessment, and even more conservative if there's minimal or absent variability. And then basically there's just a few more boxes in this algorithm because it spells out, if yes, we want you to perform intrauterine resuscitation, we want you to notify the responsible physician. Then we're doing the same thing. We're looking at where are we in labor? Are we in latent labor? Are we in active labor? Which at the time they were using 4 centimeters. We know that active labor is 6 centimeters. And then they're specifically quantifying what they are expecting for normal labor progress. And normal labor descent. And they also provide very specific suggestion to limit the second stage to 1.5 hours if you are having a persistent pattern here. So I won't read through every single step, but you can see that this is quite detailed and provides a lot of recommendations. Now, this is really assuming that there are resources available reasonably quickly to intervene. And so if you are from a hospital where critical personnel to perform a cesarean delivery are not always in-house, you would want to think about, are these 30-minute reassessment windows appropriate, or at what point would you say we need to make sure that anesthesia is available or other individuals that are necessary to help perform a C-section in your hospital? So that's where I think a hospital would want to customize this based on how long they know it takes to assemble a team for a cesarean. So both of these algorithms reference significant decelerations. Significant decelerations include what are called severe variable decelerations. And so the rule on remembering these is that it's something to do with 60. So a severe variable deceleration is one that lasts longer than 60 seconds, has a nadir that is more than 60 beats per minute below the baby's baseline, or it has a nadir that is less than 60 beats per minute, regardless of the baby's baseline. Any late or prolonged deceleration is also a significant deceleration. So the point here is that smaller variables that are shorter, less deep, are not significant, and you wouldn't even enter the algorithm if your variables are not that big. And then recurrent, again, it's defined in the algorithms, but we're seeing if recurrent, and I'm referencing the Shields algorithm here, is that it's happening with more than 50% of contractions in a 30-minute time frame. So one prolonged deceleration does not necessarily put you on this algorithm if it recovers and looks normal. Big variables that are only happening with every fourth contraction do not put you on this algorithm. Again, that's a place where people can potentially lower interventions if there is a habit of intervening in that sort of a tracing. So what does this look like? I went to the NCC website and stole some tracings from them. And so here is an example of a tracing where we might be worried about it and we would think about potentially applying the algorithm. So here we see that we have a baseline about 145, kind of looks like 150, maybe a little bit later. And we have a variable deceleration here, but it's not lasting a full minute. So it's less than 60 seconds. However, it's got a nadir of 70, which is higher than 60, but it is 75 beats below the baseline. So this would be considered a severe variable. So if we look at this tracing, similar criteria here, nadiring more than 60 below the baseline, we have three contractions with variables. This one's actually kind of late, that would be severe. And then these two over on the right-hand side would not be severe decelerations. But on this piece of tracing, for these 5 contractions, we're seeing 60% have severe or significant decelerations. So this is an appropriate tracing if this continues for 30 minutes to apply the category 2 algorithm. And so the algorithm would say that if you notice this for 30 minutes, you would want to begin intrauterine resuscitation if you have not yet already. And then you would essentially be reassessing about every 30 minutes and considering the context of where the patient is in labor. Okay. Now this tracing, I don't have all the things that are going to show up on it, but here we're having significant decelerations with several contractions, but we have minimal variability here. So we don't have as much of a tolerance. It only needs to be happening with 30%. And on this piece of tracing, we have it in 3 of the 6 contractions. We have severe variable decelerations happening, or at least 2 of them are severe variable decelerations, and minimal variability. So an appropriate tracing to apply the algorithm. Now, this tracing, we have variable decelerations, but this is absent variability. So this is actually a category 3 tracing. And so this is one where we would move to expedite delivery. This would not be an appropriate tracing to apply the algorithm. Okay. So general principles of the two algorithms, variability is really the central discriminator, really helps make sure that you are considering, what is the baby's baseline? What is that baby looking like in between the contractions? Both algorithms, I guess one other point I didn't put on this slide, I think both algorithms have a space that is you can tolerate a category 2 tracing and just observe if they are not having frequent enough decelerations to even like enter the algorithm is kind of the term that I use. If you do need to enter the algorithm that they're having frequent enough significant decelerations, then we have structured resuscitation before we move to delivery. And so the algorithms present an approach where you are resuscitating and you are reassessing at set intervals, and there's not a one-time judgment. One-time judgment is appropriate for category 3. It's not appropriate for category 2. And they're really designed to be used in a multidisciplinary fashion. So hopefully you are feeling, if you haven't seen these before, that this is some structured guidance for a more ambiguous clinical situation, which is exactly what they're trying to do. Okay. So a couple of the rationales that support use, again, remember that these were developed to reduce unexpected adverse newborn outcomes. So my second point here is, if you're feeling like, I'm not sure, maybe it's okay to just have a few more better babies and a few more cesareans. Again, be reassured that this algorithm is really designed to intervene when you need to intervene, and you're not risking the baby by following the algorithm. But it also, I think one of the biggest benefits is really just providing some objective, actionable steps for intrauterine resuscitation, reassessment, and intervention when it is necessary that can help everybody be on the same page and have kind of a shared mental model of how we're approaching this situation. All right, so I've kind of alluded to this, but I just feel like there's such a great opportunity for sort of a Goldilocks reference here of really the algorithms are hopefully helping you have a just right strategy to respond to these tracings. Again, we know that if we're over treating, if we're doing those reflexive cesareans on a tracing that might resolve, we are going to have higher than necessary cesarean rates, and we are going to be contributing either in the moment or in the long run, we are going to be contributing to increased maternal morbidity and mortality. On the flip side, we don't want to undertreat. We don't want to be not intervening when that fetus really does need to be delivered, and potentially having avoidable instances of HIE. So we want to be Goldilocks. We don't want to be too reflexive or too hot. We don't want to be unattentive and under recognizing a situation where there's true deterioration of fetal status. We really want to be just right. We want to have a strategy so that we can understand which tracings we need to intervene with expedited delivery and which tracings we do not. And again, I forgot I put a box there. This is really the purpose of the algorithms. Again, this is what the algorithms are designed to help you avoid is under recognition of true deterioration per the authors and just my experience and observing this in practice in many places. It also helps you with the too hot piece as well. Okay. So how do you do this? If you would like to introduce this into your own practice or into your organization, what are some just kind of practical tips? And this is the piece of the talk where you guys are kind of just hearing my thoughts and opinions on this. We use these algorithms at my organization. We've promoted them around the state in Iowa. We have many Iowa hospitals that very routinely use these. And I actually worked in the healthcare system where the Shields algorithm was developed. So I've had some prior experience with algorithms. So I think that the algorithms are such a powerful tool for conversations about labor management that would ideally be happening in that multidisciplinary conversation where you have the responsible obstetrical provider communicating with the nurse and the patient and the family, ideally in a bedside huddle where we would say, let's have a conversation about this baby's tracing, right? We don't have a category 1 tracing. Let's pull out the algorithm and look at it together. so that we are all on the same page. Do we need to be doing intrauterine resuscitation? When are we going to reassess? And when is intervention necessary? And I think the algorithms can help you speak with confidence to families that you are not worried about their baby right now. Or maybe you're a little worried, but you're doing things and you're not worried enough that we need to intervene. You can lean on what the Clark algorithm really promotes, that if there's moderate variability or if there's accelerations, that baby has normal acid-base status. So even if there's these big scary dips in the heart rate happening, you can reassure the family, how your baby looks in between the contractions tells us that your baby is still okay right now. And that can be really helpful to include in a conversation with the family if they're wondering why you're not doing a C-section. Okay, so some strategies of how you might actually do that on your unit. I do think that you need to incorporate the algorithms into whatever EFM education your staff and providers might be receiving. As mentioned, they are included in the A1 intermediate course, does teach them. If you're using another program or if you are doing kind of in-house EFM education, I would be teaching these in every course. I would make sure that everybody understands the purpose and the evidence for the algorithms. As I've presented today, I'd encourage people to read the articles. I'd have a laminated copy of the algorithm available in every labor room so people can pull it out and they can use it. I would make sure that these are incorporated into nursing and provider documentation templates. That can be really helpful. That isn't something that my organization has done yet, but I have seen that in other places where kind of that structured assessment of fetal well-being is templated into, you can kind of, if you use Epic, you can see how you would have some drop-down branching logic that you could follow, that you could build basically to follow the algorithm in documentation. And then I've definitely seen hospitals use it as a double check. So if they're starting to think about doing a C-section for concerns about fetal well-being, pull the algorithm out, and before we roll her back, let's just double check. Does the algorithm say that it's time to do a C-section? And if it doesn't, then let's pause and reassess and reevaluate what the algorithm is suggesting that we should be doing here. Okay. So the last place that we can use the algorithms is kind of at the end of the day when we're trying to review cases. So you may be here because you are a team leader. You probably are a team leader if you're on the call and thinking about, my hospital maybe would like to make sure that maybe we'd like to lower our C-section rates, or we just want to make sure that we're doing the right C-sections, and either as part of, an NTSV C-section reduction initiative or just in general. And the algorithms are really, really important tools in understanding where your facility has opportunity to do fewer C-sections or maybe do the right C-sections. So, ideally you would be using them in clinical practice to avoid unnecessary cesarean or to make sure you're doing the right cesareans. But again, they're a really useful audit tool to help you understand what is the current adherence to evidence-based practice in your organization. Do we have opportunities to do fewer cesareans safely? Do we have cesarean overuse occurring? But also important to ask, do we have opportunities to intervene sooner to reduce adverse neonatal events? Are we underusing cesareans in some situations? And then if you believe that you have introduced this tool to your staff on your unit, doing your audits is a way to understand if your team is actually using the tool that you have taught them. Right. I think anybody who's in leadership has probably some experience of like you thought you went live with an intervention or a tool or whatever, and then after the fact, you kind of realize at some point later that nobody's actually doing the thing that you taught them to do. So this is where audits are really important. Process measures are important. So how would we do this in your case reviews? So in general, if you're participating in a QI initiative, which I know many of you in Alabama are, the AIM bundle for safe reduction in primary C-section has a process measure to look at your NTSV C-sections or your primary C-sections, and you're essentially asking the question, was this C-section indicated? And so here's how I would suggest doing that if this isn't something that you're already doing. You want to identify cases of unplanned C-sections that were performed when the patient was in labor. So this can be a primary C-section, not necessarily just NTSVs. And then you want to look at the op note or the documentation to figure out what was the primary reason for the C-section, right? Was this for arrest of labor or was it concerns for fetal well-being? And if it was something else, then set those cases aside. So essentially, you're sorting the cases into categories. It's not always perfect. A lot of times, there's kind of a component of both. The labor doesn't progress without Pitocin. Anytime we turn the Pitocin on, the baby has more heart rate decelerations. I would, in general, look at those cases with the algorithm to understand if we interpreted those fetal heart rate patterns correctly, rather than looking at them as arrest of labor cases. Because if we aren't augmenting a labor that needs augmentation, it will, of course, meet the arrest criteria. So the arrest criteria cases you would review against the ACOG SMFM definitions. But for concerns for fetal well-being as a primary reason to perform a C-section, I would suggest looking at the last 1 to 2 hours of the tracing. May be useful to look at more of it, but that's what I would start with. And I would literally compare it against the algorithm, when did they make the decision, and you kind of walk backwards and see did we do the right things, and did we make the right call? So what that measure looks like, let's say you look at 10 cases. And so let's say you look at 10 cases of fetal intolerance of labor over the past month, quarter, whatever, from your facility. Let's say you decide that 6 of them follow the category 2 algorithms in the final 1 to 2 hours of the tracing. So you've got a 60% adherence, but it shows that you probably have some room for improvement. I don't think you necessarily need to be shooting for a perfect 100%. I think there's going to be situations where deviation from the algorithm may be reasonable, such as a growth restricted baby or some other unusual circumstance that may, cause clinical judgment to be that we need to intervene. But then what I would do is I would look more closely at those 4 cases and I would think about, can we review them in a multidisciplinary fashion? Kind of what I'm talking about here is maybe like one person is doing this. And can we just have some conversations about, what might have been going on and why might we have been hesitant to use an algorithm if we've already introduced it? And so I think these are some of the questions you want to be asking yourself when you're doing case reviews. Did my team correctly assess the tracing? The basic stuff, baseline variability, the deceleration characterization. Because I think one area that people can get into is they can get on the algorithm, but like for variables in particular, and the variables actually aren't severe variables. And so if they're not severe variables, you're not even on the algorithm. If you're having moderate variability and non-severe variables, you don't even need the algorithm. This is a tracing you just observed. And so if people get onto the algorithm with non-severe variables, then the issue is actually just characterizing the variables. They might then follow the algorithm otherwise appropriately. And so that's, one thing. So asking the question, was it appropriate to apply the algorithm or not? The other thing you want to look for is if they're not assessing the baseline variability correctly, we might be trying to apply a category 2 algorithm to a category 3 tracing. And so it's a category 2 algorithm. Category 3 is a delivery tracing. Did we do intrauterine resuscitation, right? Or did we just watch this tracing deteriorate and decide that we needed to then do a C-section, which might have been appropriate to do, but did we actually make a solid attempt at doing intrauterine resuscitation? Did we reevaluate at appropriate time intervals? Generally on the Shield, they're saying every 30. On the Clark, they're saying every hour. And pick which one you want to use. They're essentially the same because the Clark has 30 and then you start intrauterine resuscitation and then you evaluate another 30, whereas the Shield algorithm is 30, start your intrauterine resuscitation, evaluate in 30. The Clark algorithm is just watch for 60 and it's implied that you would be doing intrauterine resuscitation. So that's where Shield is just a little more specific. So did we do intrauterine resuscitation? Did we reevaluate appropriately and continue to adhere? Did the algorithm suggest that delivery should be expedited? If it did, and we did, then perfect. If it did not, then, assuming you're looking at this case because there was a cesarean performed, then if the algorithm did not indicate that delivery should be expedited and we did still intervene with a C-section, this is an overuse cesarean. Um, on the flip side, so this talk is framed through safe reduction of primary C-section, but I would say on the flip side, I would also suggest you look at babies that get cooled for HIE in your organization, and I would apply this algorithm because then the question is, should we have intervened sooner? Could we have picked up that this baby was deteriorating? And was there an opportunity for us to have intervened and gotten that baby out of that environment faster? So I do want to highlight that that would be another very important use of this algorithm, is to make sure that we're not underusing C-section in other situations. So another thing, just a tip for doing quality improvement work and trying to change group behavior, is that I think then you want to get this information that you are gathering out of doing your QI process measures, out of reviewing your cases. You need to get that out in front of your staff. And so thinking about, can you get these tracing reviews, either ones where we did the right thing or we could have made a different decision, either maybe towards a C-section that needed to happen for a baby that had a bad outcome, or not doing a C-section when we didn't need to. Get that out in front of your staff. Include your own tracings in your EFM education, de-identified when you can. It helps for people to understand, like, this is a case from our own organization. Do strip reviews with your staff. If you have trainees at your organization, incorporate this into education sessions. And then I think getting stuff out there on some sort of a case of the month to elevate appropriate care, right? Like, we want to elevate what we want people to be doing. And so if you find cases where people have optimal use of an algorithm, and they've then done the right thing, optimally used a cesarean or not, get that out there, put it on a bulletin board, copy the tracing, and you remove all your identifiers, and present that case, because we want to really spotlight the behavior that we want to see more people doing. So get it on a bulletin board, put it in a newsletter, have your vaginal victory board of folks who are achieving safe vaginal births, and really try to encourage that. All right, so these are all of my slides. So just here's where we have been in the last 45 minutes, talking about cesarean overuse, the algorithms, and some strategies to implement them. Hopefully this addresses how the objectives were addressed. But I see, I think, Fran, you put something in the chat, and I'm happy to take any other questions. Um,
Thank you so
uh,
much. That was so great. I don't know if my wording makes sense, but all the algorithm is for labor,
mhm.
and we are seeing less and less labor and more induction. And I know it hasn't been trialed necessarily in that circumstance, but I imagine that practicing where it was developed and using it in your own institution, that you're using it and applying it to inductions of labor or augmentations of labor as well. Can you speak a little bit more about that, and what, do the time frames still apply the same? Do you turn off like, we don't want to iatrogenically cause arrest disorders, so
Mhm.
much so for trying to avoid fetal well-being, but this is a constant struggle for our institution as well as a lot of my folks around the state.
Yeah. I think I saw my clinical practice, my nurse clinical practice leader from my own organization is here. But I think what I would say is a very reasonable approach that I think pretty much aligns to what we do here is, if the category 2 algorithm would not even put you on the algorithm, right? Like, you're not having frequent enough D cells to even be on the algorithm, that's probably a tracing where it's reasonable to continue to run oxytocin. You just need to be extremely thoughtful that you are not causing tachysystole, right? And as a caveat, I think we have to be really careful about tachysystole with category 1 tracings, and not putting ourselves on the algorithm because we've, like, depleted the baby of all of their placental oxygenated reserve, because, like, they seem to be tolerating it so far, right? Like, pit to distress is just going to cause distress. But I think that in general, it would be fairly reasonable to say, if your tracing is acceptable enough that you aren't even on the algorithm, proceed with inducing. if you get yourself on the algorithm, what's in the articles is, one of the most immediate interventions is to reduce or stop oxytocin, right? And sometimes, as I know you know this, Rand, like sometimes you have cord compression and you're having big variables and you just need to decrease the frequency of the contractions. You need to amnio infuse and re-cushion that cord. And then you can probably get that Pitocin back on again because you've corrected the tracing and it's resolved. And, I think most institutional oxytocin protocols would say that, then if you've had 30 minutes of a category 1 tracing, you can turn your pit back on again. Similar with lates, if you think that you have a reversible cause where, she just got an epidural and she's hypotensive or whatever, then can you correct the reversible cause, right? It gets into what some of the other EFM education programs get into is evaluate for reversible causes, address your reversible causes, and then you can sort of move forward. So to me, I think that the algorithm, it absolutely works in an induced or augmented labor. And that's where reducing or stopping your induction is part of your interventions, with the idea being that for many fetuses, you're going to get them out of a category 2 tracing, and then you can proceed with your induction. And sometimes then the tracing is going to deteriorate again, and that's going to be, you're going to walk through that, and you're ultimately going to find yourself in that situation where it's not enough. But I think sometimes, people's tracings can start to deteriorate in active labor because even if it's an induced labor, at some point their own body's labor starts to kick in and we might be overstimulating them. And I think um, sometimes we think, and I will speak as somebody who practices at a large academic medical center, I think sometimes we get so used to managing labor and inducing and augmenting it that we forget that maybe it can happen without us. And especially if, less than half of the births in your hospital are spontaneous labor, as they are in mine, way less than half are spontaneous. And so sometimes we have to remind ourselves that maybe the reason that the baby's heart rate is deteriorating is because the contractions are very strong because her labor is kicking in on top of our Pitocin. And sometimes even in that induction, turning the pit off, you might still contract and she might still progress, right? Especially in the second stage, a lot of times they will still progress. So, and yeah, Gina, chimes in. I think that that's a culture shift for a lot of large hospitals, where we're used to feeling like they really need us, and sometimes they need us less than we think that they do. Any other questions from anyone?
Come on, Alabama folks. Think about your curmudgeons, your slow to adopt, your people who have given some pushback to implementing this. I think what you said at the top of the talk was so spot on of like having a great understanding and embracing and fully recognizing baseline variability, accurate interpretation from the beginning is the challenge with our, changes in trainees post-COVID, and then also changes in our workforce in terms of labor and delivery nursing no longer being as much of a terminal career as it used to be, and just having a lot more turnover and a lot less experience. I think that just compounds what you're
Yeah.
talking about.
Yeah, and I would say so two things, for folks to think about is number one, we observed in Iowa, sometimes there was in this tended to be in small hospitals, where nurses worked lots of different spaces, right? They didn't specialize just in perinatal care. There was sometimes physician hesitation to apply these algorithms because they didn't trust that the nurses all had the right fund of knowledge to appropriately assess the tracing, and to really determine is it a category 2 or a category 3. And so we realized that for some hospitals, they really needed to first invest in EFM education, before starting to use a tool that builds on a fund of knowledge of EFM education. So that's one thing I would note is sometimes there may be a perception of physician hesitation, but it's actually an appropriate perception that we aren't actually ready for this. And then the other thing I would say is I think that sometimes physicians or nurses that may be hesitant to use an algorithm, it comes down to one of the biggest challenges with doing safe reduction of C-section work is that unlike other quality um, initiatives, not everybody believes that cesarean overuse is a problem, right? And I don't think that there are very many, if any, physician obstetrical providers out there that truly believe that they're overusing cesarean. Everyone believes that they are intervening with cesarean when it is medically indicated and only when it's medically indicated. And so they are in that loop that I put at the beginning where it is a self-fulfilling prophecy. If you intervene on a tracing where the baby is fine, and you think you're intervening because they're in trouble and you get a good baby, there's very few people who are like, darn, I had a good baby, right? Like everyone's happy that you had a good baby. And so you can end up kind of being a self-fulfilling prophecy. And so I think those folks can be brought along by reading the article. They need to read the article, and particularly they should read the Shields article that really shows that this is designed to do the right cesareans. This isn't designed to not do a C-section when maybe you're going to have a bad baby and kind of like pushing it too far. This is literally designed to tell you when the baby needs to come out. And by doing that, it also tells you when the baby doesn't need to come out. But I think that helping people understand that that is what it was developed for can help people feel more confident using it in their practice. And you find your early adopters. Um, Yes, and I love what's in here about looking at it as a team, using it to reevaluate throughout labor. Yes, it is a tool that should be pulled out and used in the course of labor. Like, yes, you can audit with it, but the real success is it becomes a clinical tool that your team uses just like any other clinical tools. Yeah, and then Fran, what we've talked about is that facilities who don't have everybody in-house need to understand what their decision to delivery um, time is. And if it is more than 30 minutes, then you need to back the algorithms up, right? The algorithms are working under the assumption that if you decide to do a C-section, you can reasonably accomplish it in about 30 minutes. And that's kind of the 30-minute intervals. And so if you're going to need 45 minutes, then you need to like literally work backwards on the algorithm and adjust the time. If you're going to need more than 45 minutes, you probably also need to think about, our system maybe needs to be able to respond a little faster than that. But I think it's fairly common in rural hospitals that it might be 30 to 40. And so I just think you need to decide as a team, when are we going to call everybody in? With the understanding that sometimes we're going to make the call to bring people in, and then in that time frame, we're going to have continued to intrauterine resuscitate, and the baby might get better, and we might not need to proceed. But now we have everybody here. We've removed those barriers to delivery if we do need to do it. I don't know, Neural, about the medical legal if it's protective to document limited resources. Um, I think it's absolutely medical legally protective to document that you're following this algorithm, though, because it's an evidence-based algorithm.
Thank you so much for joining us and for leading us in this way today. Amanda, do you want to say anything about when we'll expect it to be posted and available for folks to listen to later?
Do you know Naomi? Yeah, I'll have the recording up on YouTube hopefully by the end of today. Um, And I can actually, let me put the link to our YouTube channel in the chat.
And when we get the slides, I love some of the earlier ones talking about the how to audit it, because that's where I'm struggling a little bit, where if you try to, we're doing it sort of retrospectively and you go back and you look, did we follow the audit, did we follow the algorithm? And if there was a couple of earlier slides, I think that would really help us in that.
Yeah, I will send them.
Again, appreciate you
Thank
so
you.
much. Wish I could have you in my pocket every time I come up against a non-believer, but
Well,
here we are.
we're all doing the best we can.
I know. All right. Well, thank you so much.
All right. Thanks, everybody. Thanks for inviting me.